Okay. Good afternoon and welcome. If you want. I'm extremely honored to be mediating this panel and this wonderful collaborative event, which I had the privilege to be part of arranging and creating. My name's Nechama Munk. I'm a clinical social worker. I have a private practice, and I'm the director for Wurzweiler in Israel. When we were thinking of the trauma panel, we realized that every one of the elements being discussed regarding trauma can be a 2-hour or a 2-week course. And therefore, regarding definitions, the implications, the symptoms. So in order to be as productive and as precise as possible, since we only have 45 minutes, we thought it best to give a general definition of trauma and then present a case to our esteemed colleagues who are sitting here and can give us different approaches to how to deal with trauma. So 2 of our panelists are still looking for parking, and they will come in.
They're being traumatized. They're being traumatized
I'm
by parking.
being traumatized.
We'll help you later.
Yeah. But they'll be here shortly. And on our panel today, we have with us Dr. Dani Kahn, who's a psychologist and the director of the EMDR Training Center, which is one of the few EMDR training centers in Israel. Dr. Kahn works with a variety of populations, including trauma, complex trauma, depression, anxiety, and relational issues. We also have Dr. Tzachi Fried, who is a clinical psychologist who serves as the clinical director of Machon Dvir. Much of Dr. Fried's specialization lies in the area of personality disorders in high-risk and difficult-to-treat populations. We will have with us Dr. Einat Kaufman, who has a PhD in psychology, practices cognitive psychotherapy, and specializes in trauma and bereavement. Dr. Kaufman is a lecturer and therapist and is a professional director of the Resilience Unit Hosen Psychotrauma Unit in United Hatzalah. Also will be joining us Dr. Ricki Bernstein, a clinical social worker specializing in trauma, integrates somatic interventions with talk therapy. Ricki trains therapists in somatic psychotherapy for attachment trauma and sexual abuse. So in a very, very simplistic way, trauma is a non-adaptive reaction to a difficult event, which usually is unexpected. As you can see here, we just have a very quick definition. Trauma is emotional response to an unexpected event, like an accident, rape, or natural disaster. Immediately after the event, shock and denial are typical. Longer-term reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. While these feelings are normal, some people have difficulty moving on with their lives. Psychologists can help these individuals find constructive ways of managing their emotions. So, these things are happening. We're all safe and we're all going to be okay. Okay, so what we're going to do is we're going to present a case. And here, Dr. Bernstein is joining us. We're going to present a case, and each one of our esteemed colleagues is going to tell you how they would treat the case. So Moti came to us, and we're going to bring his case to explore and explain the different ways and approaches. When Moti and his best friend Avi were 15, a suicide bomber blew himself up on the bus. They were riding to the mall after school. Avi was killed on the spot. Moti somehow walked away physically unharmed. During the first few days following the attack, Moti stayed in his room, leaving only for the bathroom. The meals his parents brought to his room went mostly untouched, and he refused to speak with anyone despite his parents' encouragement and entreaties. After 3 days, there was a sudden shift. Moti left his room, showered, and got ready for school, as he had done before the attack. He threw himself into his studies and soccer practice, excelling in both, and became even closer than before with his group of friends. He still refused to speak about the attack. Beyond brief technical questions, but otherwise seemed to thrive. He graduated from high school, served in the intelligence unit in the Army, and started a family. 17 years later, Moti was married with 2 daughters and working as a CPA when once again he was caught in a terror attack when a car drove into the crowd Moti was part of. Again, he was physically unhurt, but emotionally shaken to the core. While he had previously been a successful account managing many accountants, he found himself unable to concentrate, and the numbers would blur before his eyes and his head. He startled easily, and he avoided walking along the main streets in his city, which severely limited his ability to run errands and pick up his children from school. Moti began to call his wife many times a day to check in on her and would panic if she didn't answer the phone. Most significantly, Moti started to have difficulty separating from any of his loved ones. He began to suffer from uncontrollable bouts of crying when his children would leave for school, when his parents would leave after a visit, and sometimes with no obvious trigger at all. Despite his best efforts, Moti was unable to control any of these behaviors. When his boss told him he needed to get help or leave the company, Moti sought treatment. So we are going to refer to our colleagues here and see what would they propose for Moti. I think we're going to start talking with you. I think you can sit where you want, if that's okay.
So I feel like this will be an interesting discussion, both where our opinions overlap and also where they might diverge. I have a feeling there'll be a lot more of the former than the latter. It's interesting to me what stood out over here was the end, and this is, I think, where personally I might start. Despite his best efforts, Moti was unable to control any of these behaviors, right? So Moti has been really involved in a lot of experiential avoidance, avoiding the emotions, avoiding the memories of what happened, and really just wanting to control his behavior. That's been his focus. And so the idea of allowing himself to experience the emotion, allow himself to experience the memory, would be a big focus here. His motivation for treatment also. Treatment involves facing the unknown, having to face what's happening inside of me. And so that would probably be a big part of treatment, talking about his level of motivation, why this is something that he would want to go through, why this is something that he wouldn't want to go through, what he would hope to gain from therapy, why his approach until now has been working for him, and where it hasn't been working for him, because to a large part, trying to avoid what he feels has helped him a lot get through life. And it also hasn't in some ways. And so helping him navigate his ambivalence in that sense. Once we've sufficiently worked on, or helped him think about his motivation enough for him to be ready to take the next step, we might start helping him learn how to think about his emotions. What do emotions mean? Why I have emotions? What's the purpose of them? And how might they be connected to my experiences, both in the distant past and also now, in terms of my more recent experience. What does the emotion feel like on the inside? How do I feel it in my body? What are the beliefs that I have about the world? How were those beliefs informed by what I went through? How have they changed? What would I like the beliefs to be? What are the automatic thoughts that come up for me in these day-to-day situations when I find my emotions being aroused? We'd probably do some cognitive work in terms of helping him respond to these automatic thoughts, in terms of helping him respond to the beliefs, understand the beliefs in context, as well as help him learn certain emotion regulation skills to learn how to recognize what his emotions are, be able to label them, identify them, and soothe them and also pay attention to when they become more intense, when they become less intense. And as he learns more about his emotions, as he learned about how he's able to recognize his emotions and regulate them a little more, we might start exposing him to some of his feared scenarios, not practically in real life, but in his head. Allow him to expose himself to the imagined scenarios that he fears now. Have him slowly get to talking about the trauma that occurred to him, both in the recent past and in the distant past. And what we would hope to find is that Mati is able to allow himself to be exposed to these memories, these thoughts, these ideas, notice the emotion come up, be able to regulate them, and as he becomes more comfortable with his emotions, as he becomes more comfortable with regulating his emotions, his functionality would come back and he would be able to functionally heal from his trauma. I'll stop here. There's a lot more to say. I'm curious to hear what everybody has to add to that. Who's next?
I think we're going to have Ricki speak next.
All right.
Hi. The first thing I'd be doing is really checking Mati's readiness to tackle his symptom, okay, of the crying bouts. And I'm going to be assuming that because he might lose his job, that he might have a lot of motivation to tackle this. And I have to have that green light before I do anything. Otherwise, I'm just knocking my head against the wall. If the client isn't ready to be without the symptom, okay? So my approach, the somatic intervention approach, involves a great deal of psychoeducation that is focused on the way the body remembers. Our assumption is that trauma is about your body's response to the event. It's not about the event. It's not about what exactly happened, because we all know that so many people respond differently to the same event. It's about your particular nervous system and how it remembers, okay? And so I'm stressing this because we understand that insight is of limited value in helping Mati right now, at the beginning. Way farther along in the therapy, that would be a place for insight and for facing his emotions, because it's the fact that he doesn't have the affective capacity, he doesn't have the ability to hold or face these emotions. That's how he got to this place to begin with. So I wouldn't be starting with the emotions, I'd be starting with teaching him how to regulate his body, meaning when I say body, I'm not talking about touch or massage, I'm talking about the nervous system. Okay, so I'd be busy teaching him about how the body contains stress and how we have a finite capacity. And what has happened to him is he's just had one big drop too much in his cup, okay, and he has overflowed, literally and figuratively. And he can't contain any more stress happening to him. So the first thing I would tackle would be his crying bouts. And I would view them as a habit, a repetitive habit that needs to be interrupted. And I would teach him how he can interrupt it. How can he interrupt it? Well, sort of on one foot, I'd be using his breath, which is the only voluntary access that we have to an otherwise involuntary system. Okay, and by teaching him how to use his breath to sort of put a brake on this runaway out of control experience, he'd be able to learn to halt the cycle or preempt the cycle when it's on its way. And this ability that he'd be learning would be building up his sense of his ability to handle things. The more he's able to master something like this, the more he's going to grow to trust his body's capacity to deal. Okay. Yes, exactly. Thank you very much for that. So I'll be busy teaching him how to regulate his fear response, enabling him to lessen the fear, to modulate it, to control it. For him just to be able to control his body's response is going to give him a sense of mastery and a sense that he's on the road to improvement. And of course that's going to increase his control and functionality. And then I'm going to get to processing after I've organized the difference between then, when he was 15, and now, 17 years later, because there's a lot of work in separating those two things. I'd be busy working on his sensory memories, both of the initial bus and the later car. And by working on that, I'm talking about memories that have to do with sound or with sight. So the approach is sensory and not the story so much, okay? And all of this is going to lead him to a place where he feels able to face the loss that was never felt and to deal with the emotions that were never met. Well, thank you.
Dr.
Thank
Kahn.
you, thank you.
Thank you. First of all, this is a horrible form because I like moving, and now I have to stand over here because this is listening to me.
Can do some,
I could breathe, yes. Okay. So I'm actually going to start with how we understand from an EMDR perspective. EMDR stands for eye movement, desensitization, and reprocessing, and that's why we call it EMDR, because nobody wants to say that whole sentence. And there are certain parts of EMDR that are a little bit weird, including those first two words, eye movement, and hopefully I'll get to that within the next 7 minutes of clock. How much time do I have? 7 minutes? 7 minutes of clock time. But the first thing that I'd like to do is, first of all, Matti is not real. He is none of us, but he is also potentially all of us. This is a story that, as a panel, we made up this story. And what I like about the story is that it really demonstrates some of our understanding of what is trauma. Trauma is not the event, as some of my esteemed colleagues have already mentioned. It is how the system responds. So one of the things that we know about memories that are stuck is that we do one of two things. Either we avoid thinking about it, or when we think about it, we drown in it. And that means that the brain does not manage to process through the information because the information remains stuck. When I say that somebody drowns in it, it means as if reliving it, or on some level it becomes once again outside of their window of tolerance. So when that's happening, it's a re-traumatizing event when it comes up again. And avoidance also means if I'm not thinking about it, I'm not bringing it up, I'm not processing through the memory. Another thing that we know not about trauma is that our brains, our system, is actually very, very good at processing information when it is inside window of tolerance. So when EMDR approaches a case like this, what we're really doing, first of all, it's an 8-phase treatment that starts off with taking a history and understanding what's happening, and we were already given the history over here. The next thing that we do is we want to make sure that the person has the proper preparation for being capable of processing through the information using the methodologies of EMDR. One of the important things about EMDR itself is that while we are bringing up memories, we are helping a person keep 1 foot here, 1 foot in the present, 1 foot in the past. Because that's part of what allows and helps a person to stay within window of tolerance while we are working on a memory. Now, the exact order that we would work on it really depends so much on how he presents in the office. With some of our clients, we might start with the later trauma, the more recent one, and because that's the one that is more flooding the person in the here and now. With some cases, we might actually float back and start from the beginning, start with the roots. So there's some of the information that we're getting over here. We can't yet know exactly what would be the right way for us to approach this case. But the thing that's weird about EMDR, this is the piece that, since we're all all of us are trying to point out what's different about our approach. What EMDR does is once we bring up a memory that is stuck. In other words, it's not processing. And what we want to do is click in the natural healing process of the brain system. When I say brain, I want to be clear, I'm not just talking about cognitive, I'm not talking about thinking, I'm talking about all the levels that the system holds onto a memory, which includes our sensory input, the memory of our sensory input. It includes cognitions, which we've heard from one, we'll hear from others as well. It includes emotions, it includes body sensations. And what we're trying to do is really bring up the memory with all of its colors to allow all of those parts of the memory to be capable of going through processing. As soon as we bring up the memory, that's when we start the weird part. We ask a person, follow my fingers with your eyes, and allow whatever needs to happen. Now again, this is bizarre. I'll tell you very honestly, when I first heard about this form of therapy and somebody was pushing me, you gotta come learn this stuff, I said, really? I'm gonna sit there and I'm gonna go like this and say, watch my fingers and take money from people? I mean, that was beyond bizarre. And then I started reading the research. And the research was fairly convincing. And then, so I finally went for the classes and I haven't looked back. And what we find happens very often while we're doing this work is that the level of disturbance, while a person is accessing the memory, the level of disturbance begins to go down. And in a natural way, while we're doing the processing, we're also able to see that the way the person is holding it, in terms of its meaning, in their daily life, also it begins to improve. It goes from a negative emotion such as I can't handle this to something like I have choices how to handle this. It was my fault. I didn't deserve to survive. To my friend would want me to live a full life. Some type of changing of meaning of the event. Okay? So again, what we saw with Matti is that he was avoiding it at all costs. He couldn't touch it. So of course it never got processed. Later on, he was getting completely flooded. Again, it can't process. When Matti comes into the office, what we're trying to do is to help him go into that natural processing. And the last thing that I'll say about EMDR processing is that we will identify both the past events that are stuck. Present triggers also get treated because they sometimes have a life of their own, moving into practiced future events that help somebody to be able to live their life in a more effective way. I probably could go on for another 7 hours, and I understand my time is up. So.
Hi. I was thinking what I'm able to add after I heard and listened to so many smart things. So I'm going to get a different point. I will, as you can see, I'm wearing my vest, and we are the emergency team of the United Atzala, the Chosen team. We are EMTs all. And I was thinking about how am I able to deal with this case in the field. It's like I have a call from his wife and he's having a panic attack or something really bad happened to him. So what am I supposed to do at the moment I get there? Not in my clinic, as my colleagues offer a really good therapy. So what am I supposed to do over there? Okay? So usually we're going to work with him with EMDR methods as ISP to help him to stabilize himself, to be less disconnected and be focused on the here and now. So that will be the first thing that we're going to do. And the second thing, we're going to work with him by the VIOS model, which is my model actually. It's my new baby. So the first method will be the ventilation part. We are going to actually listen to him and let him to talk and to explain his side, his story, and in a fluent way. We don't want to bother him. We don't want to stop him. Just talk freely and fluent, and of course non-judge. And the moment he will go and take a long breath and I say, okay, I finished. That's my story. I'm going to be as a therapist move into the orientation part, to a little bit organization part. I'm going to try to help them to give them a little bit more information. For example, that we are right in the here and now, and what is thinking about that and is talking about that. I'm going to ask him, is this really a fact that's happened right now, or perhaps it's your thought. Perhaps you remember something. And the moment we're going to start to distinguish between thoughts and facts, in my experience, people start to stabilize themselves. They start to like calm down because, I'm sorry. Okay, sorry. So in this moment, people start like to thinking in a different way. So every time I say, oh no, my God, that was a thought. I just remember that. And I'm going to try to focus him in the here and now and the facts that they have here and now. Are you feeling right now in danger? Okay, do you need something? I'm going to try to help him to get back to his control. What do you need right now? How can I assist you right now? Sometimes in our experience in the field, people forget the basic things. Like, I want to call my wife, I have to take my medicine, I need to drink some water. And it's fine, because this is actually being in the here and now. The second thing, the third part, that will be like organization. I'm going to try to go with him for the first steps by taking a few decisions. Okay, what would you like to do right now, like in the next upcoming future? Okay, would you like me to stay with you? Would you like to go home? And I will try to help him to move from side to side, to start thinking, what does he need right now? And in the last part, I'm going to ask him, what usually helps you? This is like the self-care, okay, self-help. What usually helps you when something like this is happening to you? So usually people say, when I pray, when I walk, when I listen to music, when I have a chat with my friend, when I cook, when I clean, doesn't matter, okay? Whatever is help you, and then I'm going to help them to like make a connection between the past, the present, and the future, okay, by the whole steps. And this is like a method that we're actually used in the field because we have like 15 minutes, perhaps 1 hour to assist a person, and then we're never going to meet him again. So I want to be with him and to help him to be focused in the here and now. And I always explain them that this is their power to understand right now. They can, like, suffer is part of life, as we all know, okay? I love the ACT therapy of, like, I listen to Harris all the day in my mind. And he said, and he's talking about that suffering is part of life. The thing that you have, you can have the control if you want to have it in the high volume, in the low volume, and only you know how to reduce the volume. So, of course, in clinic, if I want to meet him a few times, of course I'm going to work like classic therapy. But in the field, we want to we want to help him to create a new narrative which is going to be really cohesive, to empower him, to feel that he has the power of control and is already able to take decisions, like asking someone, go back to the daily based self-care that he always used. And this is our help, okay, to normalize the unnormalized reality that is really happening right now. Thank you.
Einat, I think that what is extremely important to acknowledge is that when people are helped in the scene, that it usually helps prevent the PTSD, the trauma being stuck, and moving it into something more severe. So I think it's extremely important. Questions? Do we have any questions? Yes.
I have two questions. First of all, in this definition, or in the slide before, the definition of trauma was very specific, like an accident, a very short-term event. What about longer-term events? Are those also considered trauma? Like, people talk about, that they grew up with a whole childhood of abuse or an abusive marriage or, some longer-term experience. Would that also be considered trauma and also be these kinds of things be appropriate therapies? And my second question is for the EMDR, can that be done virtually as well, or is that only in person?
Okay, so since you actually, she already handed me the microphone. First of all, we can make a distinction between type A and type B trauma. Type A trauma are these kinds of things that we saw on the first slide. Type B traumas are these kinds of repeated, continuous events. They could be from the long, distant past. They could be more present. But we do have another definition of trauma. And another thing, at least for EMDR, and I believe that many of my colleagues would agree with this, is that it's not, when we're actually in the clinic, it's not about the event. I think you said that. It's really about how the person's responding. It's how the information is stored, whether we're going to be looking at it from a more cognitive perspective or from a more body-centered perspective, or the way I talked about it in EMDR. The second question as to whether or not EMDR can be done online. I started doing EMDR online about 10, 12 years ago, so that when Corona hit, I was one of the people that actually had a lot of experience doing it. And in the interim, there's been a lot of research that demonstrates that many forms of therapy can be done online, including EMDR.
Thank you.
You're welcome.
Is your work with 32-year-old Mufti the same as the work with 15-year-old Mufti, or does it change based upon what has happened?
So I think we're going to ask the different panelists that question.
The work with 15-year-old Mati is going to be different in some ways than the 32-year-old Mati, and that's because Mati at 15 is different than Mati at 32. We're all different. A lot of often the starting point in therapy for me is motivation. Why are you here, and what are you looking for? What is it that you want? 32-year-old Mati didn't want to be crying all the time. He didn't want to be constantly checking up on where his wife is, where his kids are. It was probably kind of annoying for them, and he doesn't want to lose his job. So that's really what he wanted. There was something that he came into therapy for. 15-year-old Mati, he didn't want to be in therapy. He was forced to be in therapy. He didn't want to think about what happened. He didn't want to talk about it. So the work with him would look quite different because Mati is different. What would it look like? Probably depends on who 15-year-old Mati is.
Ricki?
I love this question. Essentially the work will be the same because he has the same nervous system that he had when he was 15 and the same habits. If anything, at 32 it's going to be more complicated because he's developed more intricate ways of protecting himself from feeling, more elaborate avoidances. Okay, so of course the way I would speak would be different because you connect differently with an adolescent than you would with a grown-up. Okay, but I'd still be working on teaching him how to use his capacities, in the same way.
So I'm similar to Ricki in this, that the basic style of work is similar, if not identical. Of course, there are developmental differences, and therefore the work has to be appropriate to the client, not that the client has to make themselves appropriate to the work. And that's always the job of a therapist, is to make ourselves appropriate to what the needs are of the client. But I'm going to use your question as a jump-off point. Very often, one of the things that we see in the trauma response when a person is in trauma space is that they're actually stuck in time and space. That's what a flashback feels like. The response that he's having in the here and now is not the response that's happening because his wife didn't call him. His response is happening now because a bus is blowing up around him. That stuck response that never got dealt with is stuck at 15 years old. When we get into much more complex cases of complex trauma, early childhood trauma, ongoing trauma, at those points we'll even have fragmented parts of self that need to be treated. And when we get to those aspects of self and those parts of self, we're working with a child. So it's whether they're 32 or they're 15 or somebody comes in at 5 years old, I could be treating somebody when they're 95, and I'm going to have to deal with that 5-year-old part as if I have a 5-year-old in the room. Now, that's not all the work that we do, but it can happen. So I just used it as a vehicle to discuss that as well.
Okay, we have 2 more questions that I see. Okay.
I'll give you by an example. Let's say a child who is under 2 and doesn't have a memory of what happened, and they were abandoned. Right? So it's very possible that they have an attachment-related trauma. As they grow up, every time they feel abandoned or whatever, that thing comes up, but they don't know for sure that it's connected to that thing.
Right.
So how would that be treated when there is no memory whatsoever. And the second part is, can
Making it complicated.
what?
You're
Oh,
making
it's
it
easy. We
complicated.
can handle that in 2
I'm sure
minutes.
you can.
The second part of the same example, can it be that someone who has no memory might have absorbed the trauma of other people involved? So for instance, if this child was abandoned, the older sister suffered a terrible trauma, and so the child is absorbing the trauma of the sister, not so much the trauma of what actually has already happened, even though according to many psychologists, any child who is abandoned under a
Right.
certain age, there is that possibility.
Okay, did everybody hear the question? Okay. So the question was regarding a case of a child who was abandoned when he was 2, and the memory is not accessible. Is that correct? So how would you deal with that? And how would you deal with the child reacting to a sibling's or a family member's reaction, which created a trauma as well? Correct? Ricki?
So on the issue of memory, we have memories. We just don't have the language at the age of 2 or younger. So all memories, I'm going to say not just from birth, but from the womb, okay, are remembered in a sensory motor way before we had the capacity to speak or assign language. And so if you want to access memories that early, you would work in a way that is sensory and motoric. And then you would get, for example, just a tiny example, you would get to the experience of what's it like to cry and not be answered. Okay, just that. And the older sister, we all, anyone in the profession knows that we can observe and absorb traumas that are around us.
Thank you. And the other panelists would love to comment as well, but we have another question. So I'm actually going to go to you.
Shalom everybody, I'm inaugural from Moshav Modi'in. I'm from Rabbi Shlomo Karlebach, the community. And I founded, after my divorce, an organization named Amen to prevent divorces and suicides caused by Zalapoal, we could say, to make it short. Whoever doesn't know it, there are Dickensian laws in Israel in which your whole you get financially killed, you end up in debt. Now, normally, the man is the one who goes through it, and he has to be a man, a strong, macho. So he grins and bears it. And then another slap on the face comes from life. Could be...
Do you have a question for the panel?
Yes, I am defining the question. My apologies. And eventually, suicide is triggered. Now, how do we deal with cumulative trauma?
Community trauma.
That's what I want to know.
How do we deal with community trauma?
Communal
Communal trauma.
Community.
Community. Accumulative. Thank you.
Cumulative or cumulative?
Accumulative. Okay.
Yeah, we got chest up. Okay. So cumulative trauma is what we're talking about, those category 2 traumas, the category type B. And absolutely we can work with those as well. One of the things that we know, for instance, about suicidality is that when a person believes that they do not have any way of dealing with their day-to-day stresses, and there's a full belief that the only way to be able to escape the suffering is by leaving. That kind of belief system, from a cognitive perspective, from a body perspective, it is a fully true belief for the person because it is sitting on top of, usually, very difficult events that a person has been through in their lives. Another thing that I'll just say about this cumulative trauma, and probably every trauma, is sitting on at least 3 things. Number 1, when the thing happens, it feels unsafe. Number 2, it feels like it's not happening in our control. Number 3, we feel utterly alone. Good trauma therapy has to return all three of those things: relative safety, a sense of control over the therapeutic process, as well as a sense of connection. So I think that everybody that would agree with me that these are big parts of what we're doing in good trauma therapy. So cumulative trauma is exactly what we deal with. Regarding the question about when we don't have a memory, there's always a memory. First of all, we have a motor memory, body memory. In addition to that, there are triggers later on. And triggers are, the way I like to imagine it is that a trauma is not just a room itself, it's an entire mansion. The central room might be the initial event, but there are many things along the way that has triggered it. And all we have to do is, first of all, get inside the mansion. Once we're inside, we're able to start treating the stuff that's there. And vicarious trauma? Oh boy, I treat therapists all the time. Because we deal with some hard stuff. I have my colleagues and students sometimes treat me. Some of the stuff that we hear in the room is really hard. And I'm trained to deal with the stuff. So yeah, when you have an older sister, watching abandonment happen, yeah, that could be really traumatic.
One last question? Yes.
Walk along the streets. One thing unless I was spacing out, which is highly possible, was exposure. Where does that play a role in helping someone overcome a trauma?
The question was about exposure therapy. People who have been through trauma, what role does exposure therapy play in trauma? So for many, but not all, of the traumas, there is an exposure component. You don't necessarily want to expose a person to another terrorist attack, although there might be, first of all, one thing about exposure therapy is that it's critical for the person to be ready and willing to face what they fear. It's not something that you want to really push them into. It's not something that you want to do before they really feel ready, before you as a therapist feel like they have the tools and the skills to be able to ground themselves and regulate themselves and get themselves through it. But when they are ready, so exposing him to something like walking down the street without checking in with his wife, going 5 hours without checking in with his wife, allowing his kids to go to school, without bringing him down and crying, slowly getting him to a place where he can experience the things that he used to experience without re-experiencing the trauma. He might even revisit the place where the terror attack happened at some point. But it's something that's done in a way that they're ready for it, in a gradual manner, and in a way that doesn't lead to them becoming worse, at the very least.
Okay, I'm going to thank everybody very much for joining us. I think that we realize that we're all different as human beings, and different things will trigger us, and different things will work for us. And therefore, it's so important to have all the different dimensions and approaches. So thank you very much, Ricki, Einat, Dr. Kahn, Dr. Fried, for joining us.
They're doctors also. What's Ricki? Dr.
Sorry. Have a good afternoon. We're going to clear the room so that the next panel can join.
I do not accept that. Ricki.